That's the message Wilk is trying to convey tonight. So let's get rolling. Please join me in welcoming our moderator for this evening's program, Wilk Wilkinson.
All right. Thank you, Bill. All right, good evening, everyone, and yeah, welcome to Temple University for this Braver Way or Braver Angels presentation on pandemic policy. I think Bill covered a lot of what I was going to cover in my opening notes here, and since we're already running a little bit late, I'm going to give you the abridged version of why we're here. The pandemic affects every corner of all of our lives. And the way the pandemic was handled affected every corner of our lives. And in some ways continues to do so. And there has not yet been a lot of conversations on that brings together people from both sides of the issue and how we can reconcile what we've been through. And one of the things that I've been doing with the Truth and Trust Project here at Braver Angels is bringing together people for courageous conversations. And that includes the work that I've done with Dr. Francis Collins, and I continue to do with Dr. Francis Collins, the conversations that I've had with Dr. Jay Bhattacharya, now leading the NIH, and some of the world's most esteemed medical professionals. It's been incredible. Tonight's particular topic, since this is a very big one, we've had to kind of rein that in to the use of NPIs. NPIs, non-pharmaceutical interventions, was a big part of that because that included how our children were kept out of schools and why our children were kept out of schools. We have two incredible speakers here tonight who have expertise on this subject. One is investigative journalist David Zwig, my friend David Zwig, who's an investigative journalist whose work has been seen in the New York Times, the Atlantic, Wired, the Free Press, and he continues to contribute at times for SilentLunch.net. He wrote an amazing book called An Abundance of Caution, talking about NPIs, the government's use of NPIs during that pandemic response. Our other speaker tonight is Dr. Machek Bonnie, an incredible epidemiologist who works here at Temple University. Dr. Boni has more than 15 years experience in the field of epidemiology, epidemic and outbreak response, and quantitative analysis in epidemiology. He sat on a dozen World Health Organization committees evaluating vaccine deployment plans, responses to drug resistance epidemics, and worked with several local health organizations and his local school board to try and help with their COVID response policies. So these are two people who very much involved in the COVID response, but on both sides of the issue. And they're going to come together tonight to have an incredible conversation. And I'd like to welcome these two friends of mine to the stage. David Zwig and Dr. Machek Bonnie, please come up here and join me. Thank you for... Now, as Bill said, the Braver Angels organization does things in a structured way and works with certain principles to make sure that these conversations are had in a meaningful way where people can get together and learn. They listen, not just to respond, but to understand the other side of the issue. I want to quickly go over the principles of the Braver Angels way, and then we'll get started with our conversation. We state our views freely, fully, and without fear. We treat people we disagree with honesty, dignity, and respect. We welcome opportunities to engage with those whom we disagree. We believe that all of us have our blind spots, but not one of us is not worth talking to. It's a hugely important thing, especially in a conversation like this, because a lot of people were not listened to and not talked to as a result of how they came to believe what they believed. We don't do that at Braver Angels. We seek to disagree accurately, avoiding exaggeration and stereotypes. We look for common ground where it exists, and if possible, find ways to work together. We believe that in disagreement, both sides can share and learn. And at Braver Angels, neither side is teaching the other how to give feedback or what to say or how to say it. Even things that we may disagree with vehemently or sometimes get us triggered. It's very important. So both speakers care deeply about truth, transparency, and the well-being of our society, even if they interpret the data differently. We'll begin by giving each speaker 3 minutes, and I've asked them to reflect not just on what they believe, but why they believe it, and what assumptions do they hold, and so importantly, how do we rebuild the trust that so many people lost during the pandemic and the pandemic response? So David, let's start with you. Please take about 3 minutes to David. Take about 3 minutes. Thank you.
Great. Thanks so much to Wilk for putting on this event. I'm thrilled to be here. So my name's David Zwig. I'm an investigative journalist, as Wilk had said. In the beginning of the pandemic, like many of us, I was completely lacked knowledge about what was going on. I had no reason to disbelieve what I was being told. And I went along. I lived just north of New York City. My family and everyone else around us went along with the instructions. We, stayed home and tried to flatten the curve, as we were told. But I also observed very quickly that my kids were alone in their rooms for day after day. And the question that started to circulate in my mind was, well, how long is this going to go on for? Now, of course, if you're comparing a child sitting in their room, sequestered in there for some period of time, that versus death, that's an easy decision to make. But one of the things that I'm really interested in is how we think about our values. And one of the, I think, most damaging elements of the pandemic was the way that information was weaponized to the American people. And one of those weapons that was used was the phrase, follow the science. And what I argue is that there is no such thing as following the science, because science doesn't tell you what to do. Science is a process of gathering information, and then people, based on their values, make decisions. I'm very, very apologetic for showing up late today. I left plenty of time, but sure enough, the New Jersey Turnpike had its way with me. There was an accident and a huge backup. But it's actually a really important metaphor for what I want to discuss, which is, in our society, we don't consider risk mitigation to be the highest value of all. Our highways have speed limits of 55 or 65 miles per hour. We could make them 25 miles per hour. Far few people would get into accidents. Fewer people would die. But as a society, we're willing to tolerate a certain amount of death and harm because we want to get places faster. We all get into our cars and go very blithely, knowing there's some degree of risk, but we do it anyway. And that's one of the things that I believe was lost during the pandemic. Things were framed as a matter of, do you care about people dying? Are you a good person or a bad person? Well, being a flourishing human being is about more than just the avoidance of death. It's about making decisions about different things you value. And there's a reason why we all get out of our homes every morning. When you step onto the sidewalk, you do put yourself at risk.
About 30 seconds.
But you're willing to take that risk because that's part of leading a good life. So that's one important theme. And dovetail to that theme, I also will argue, is that what we were led to believe was this sort of choice between safety or death wasn't even the correct framing for what was happening. That by and large, the choices that we were given about what we could or what we should or shouldn't do didn't even achieve what we were told these things would achieve. And that's what I would like to talk about tonight.
Very good. Thank you very much, David. Dr. Machek Bonnie.
Hi, everyone. Thank you for coming to Wilk and David as well. My name is Machek Bonnie. I am an infectious disease epidemiologist. I'm also a professor of biology here at Temple University. Wilk's already introduced a bit of my background, so maybe I can tell you a little bit about why I'm here and why I think we're all here, is that we've seen this year in 2025 a renewal in the loss of public trust in science, loss of public trust in public health. We saw a lot of it in 2020 and 2021, but we saw it come back up again this year. There's probably two major reasons for it, which I'm sure we're going to get into. But Wilk asked me to sort of talk a little bit about my beliefs, and I thought because we're doing COVID policy, I would just kind of mention what I thought like the two biggest successes and two biggest failures of COVID policy were. And again, I'm sure we're going to get to these. I think the biggest success was Operation Warp Speed, getting a vaccine designed, tested, and manufactured in 10 months, which I think a lot of people agree with. I think the second biggest success, which is underrated and not talked about, is that we got the U.S. population. So we here is all of us. We got the U.S. population from March 2020 to March 2021 to March 2021 with just 25% of the population infected. So that meant that when vaccines were available in March 2021, you had 240 million people that hadn't yet gotten infected, and they could now go freely get the vaccine and be free of all the adverse and severe potential consequences of getting a COVID infection. This, I think, is one of the things that doesn't come up enough, and I think we need to talk about today. The two biggest failures, I think the first one was leadership. Wilk and I have talked about this. There wasn't any, or certainly not enough, and I think a lot of the problems can be traced back to leadership. And number two, I think David's got it spot on in his book. It's what happened to kids being out of schools, all the other detrimental effects that happened to kids that were, either in abusive homes or had worse consequences than just learning loss. And whether it was preparing schools for the pandemic, what happened during the pandemic, or how we reopened schools to get kids back in, I think there were a lot of failures there. Mm-hmm. So these are kind of my initial contributions to my beliefs, and happy to talk about what you guys think should go next.
Fantastic. Thank you so much, Dr. Bonnie. Just real quick, would you rather me call you Machek or Dr. Bonnie?
I would, yeah. Machek.
Machek. Okay.
Yep.
Okay. I just wanted to make sure. I always ask people, whether it be on my podcast or when I'm doing conversations, I always ask people what they would like to be called, and I appreciate that. Thank you so much.
You did say Dr. Zweig before, which isn't correct, but I liked it. So if you
want
to continue with that,
yeah,
my parents would be very pleased.
See, I love the power of editing because I screw up a lot, and no, I appreciate that. So if it will make your parents happy, no. All right, here we go. So yeah, we got a number of questions, and we'll kind of see where things go with these questions, and kind of just go where they lead. But I've got some questions that I'd like to ask. So I'm going to start off with this one for you, David. In your book, An Abundance of Caution, you often describe MPIs as having little or no measurable benefit. What led you to that particular conclusion, and what data point do you see as the most compelling? And again, we'll try to keep the answers right around 3 minutes, and see where we get to.
I think one way to frame things, just starting off, is I don't know if my worthy is adversary. I don't know if we're adversarial.
This is a collaborative
partner,
inquiry between two people of differing opinions.
Maybe not even all that different. Sorry, there's not going to be fireworks with that. But I don't. A way I would like to frame this is, and Machek may disagree, which is that I'm going to try to avoid citing study after study, because most likely we could go back and forth, and one person can say, yes, but what about there's this thing in the New England Journal of Medicine? I'll say, yes, but what about the one in JAMA that says this? And we can go back and forth. And to me, what's more persuasive was when, and this is a large part of my book, is looking at sort of the most baseline empirical evidence. And one of the ways we can look at this sort of success or lack thereof of NPIs without delving into studies where the authors of the studies get to choose the parameters, when it begins, when it ends. They get to choose what inputs go in and what inputs are out, is we can use something very broad and crude, which is the death rate or the excess death rate. Excess deaths are any individual population or region has a projected number of deaths in a given year based on the population size and how many people they expect to be born and die in a given year. So excess deaths are any number of deaths beyond that expected amount that you would statistically think you would see. And what we saw was that there's no correlation in the excess death rate between different areas that were very, very strict with NPIs and other areas that were far more lax. And the sort of two poster childs for this might be Florida and California. You had one state that by the fall, the schools by and large were open. The population by and large was not complying with masking or even required to do so. There weren't limits on gathering. There weren't distancing requirements. And all of these things were pretty lax in Florida, and notoriously so in the press. They were vilified for this. Then you have California, extremely high compliance for universal masking. Kids in that state, healthy children, millions of them did not step foot in a school building for over a year. You had limits on gatherings. I wrote a long piece about a church there that defied regulations in Santa Clara County, where they were not allowed to gather beyond a certain number of people. So you had a very locked down, quote unquote, state and a far more laissez-faire state. And in the end, the rates were about the same. Once you adjust for the age difference between the populations, all of that was for nothing in California. And I believe even the rate of COVID deaths itself, the thing that all these mitigations were really geared toward trying to reduce, even that, once you make some crude adjustments for the difference in the demographics, those rates also were the same. So to me, you don't need to trade studies back and forth. You can just look at these very basic data and you can see that in the end, these measures that everyone did, and it's a hard pill to swallow, really had no effect at the end of the day.
Very good. Thank you very much. And Maciej, when you look at the early months of the pandemic, especially, you and I had talked a lot because you were highly involved in this in the early months in 2020, 2021, and early 2022. What data or patterns convinced you that certain interventions were actually working and helping in some meaningful way?
I mean, in the early months of the pandemic, we didn't have any data yet from this pandemic. So in the early months of the pandemic, you had to go on the effectiveness of NPIs as they had been seen during other epidemics or pandemics. So what did data from 2019 tell us, or the 2009 swine flu outbreak? Does closing schools matter? Does it help kids lower their incidence of respiratory disease? Well, the data from before the pandemic told us that it did. And then as the pandemic moved forward, some of our assumptions were violated. We learned some new things about, for example, how kids do or don't transmit COVID. And as that year went forward, we learned which NPIs seemed to work and which ones didn't. And there's no certainty here. David's kind of right that you can look at a lot of studies and get slightly different results about one type of NPI being more effective than another. But I'm just going to respond to David's Florida and California point directly, because this is true. When you look at all 50 states and you adjust for the fact that some are older, Florida's older, some have higher population density, Florida does, some have larger household sizes, Utah does. When you adjust for all these things, you can tell how well states were supposed to do during the pandemic. And Florida kind of did about average. It wasn't, it was vilified in the press because they did relax their mandates faster than blue states, but slower than red states. So maybe that was one of the reasons. And California did worse than expected. Not a lot worse, but California did worse than Florida. And this example does tell us that, these things are surprising. When you look at all 50 states, the story's less muddled. So when you look at the top 10 overperforming states in the pandemic, the states that did kind of well based on how well they were supposed to do, you get New Hampshire, Vermont, Maine, Washington, Oregon, Hawaii, states that did have strong messaging about wearing masks and not having large gatherings. You also get Utah and Alaska, two Republican voting states that for some other reasons seemed to have done the right things and had low COVID deaths during that first year. When you look at the worst performing states, the states that underperformed, you get Mississippi and Oklahoma, Alabama, Arizona, and these are states that already had challenges and seemed to even underperform those challenges. And you also get New York and New Jersey, always kind of in that group of bottom 7, bottom 8 states, probably because they saw the pandemic very early. I'm not sure. But the picture's a little bit less muddled when you group all 50 states together and kind of try to see who followed and who didn't follow, or who had certain recommendations and who didn't have certain recommendations.
Okay. All right. And just as a follow-up, I can give you each about a minute to kind of do a little back and forth there.
Sure.
If there's something, when you start thinking about the state by states, and I think the Florida and the California thing is generally a pretty good comparison. But yeah, there is more data than that. So
Yeah, Machek probably knows the data better than I do on this, on the individual states. But to my mind, I think that also sort of supports my point that once we start, Vermont and New Hampshire are quite different from Mississippi and Alabama, and the underlying health of the populations in the states, and the demographics, and how the density of the areas. And of course, the scientists will control for these things. They'll try to control for them, but the world is complicated. And again, I spoke with an oncologist during the pandemic, who his practice now is he talks with cancer patients to just walk through the various options for their treatments. And he's a EBM guy, which is evidence-based medicine. And he really believes strongly in that. And I was talking with him about schools being open in Europe, and how there were numerous experts, quote unquote, saying that we should dismiss this. It doesn't count. That's Europe. It's different. There's this. That's because they did this or they did that, and it doesn't count. And I said, can I still talk about Europe? Is it wrong that I'm saying this? And he said, David, you don't need a study for this. It's the real world. It's even better than a study, because there's no one pulling the marionette strings. There's no scientist deciding what goes in and what goes out. You can see there are millions of children in school there, and it's just an open world experiment. This is empirical evidence.
yeah.
So I think we'll get to the Europe conversation probably in a minute. But I just wanted to underline David's point at the very beginning of what he said, which is a really good one, that these states are different. And Mississippi has different challenges than New Hampshire. Hawaii and Florida are totally different from each other. And David's right. We shouldn't have been looking at all of them the same way. And an under-talked about part of this pandemic is that if you're the governor of a state where you have high population density and a lot of pre-existing conditions and maybe higher obesity than average, you should not be aiming to just be average. If your state has a lot of challenges, I think in some of these places, the governors should have seen that and understood it, and should have made more of an effort to explain, communicate, protect their residents as much as they could. This is something that I think wasn't done, and to much of the post-pandemic discussion, I think wasn't even talked about.
It wasn't talked about. It's something that I've talked about quite often, is the whole one size fits all thing, and how that there was no way to look at the whole, the United States, different climates, different, population densities, different issues in different places, rural, urban. These things were not properly accounted for. It's something that I've obviously talked a lot about, with Dr. Francis Collins, Dr. Jay Bhattacharya, both of them, definitely have spoken about that. So let's, and we will get to the international thing a little bit, but there's one thing as we kind of lay the groundwork for that and get to that, David, there's another thing that you talk about, or you've written about extensively, and that's that children generally experienced mild COVID and weren't prominent spreaders. So closing schools was an unnecessarily overreaction in most cases. Can you walk us through that particular argument?
Well, early on, much of the argument was made that we should close schools for children's safety. The narrative shifted at some point to once the data became just more and more incontrovertible. Well, we're not doing this for the children. We're doing it for the teachers. We're doing it for the community. That's why we need to do this. So there was a bit of a narrative shift from it wasn't just school closures weren't exclusively for that. But if you go back and you actually look at the statements from people like Andrew Cuomo, who was the governor of New York, and you look at New York Times articles, media, children were mentioned all the time. So there was this sort of official thing where it's like, yeah, it's not for the kids, it's for the community. But note, anytime teachers unions, anytime Cuomo, these people, they always manage to sneak in and safety of the children. So there was a bit of a false idea that there was like an official narrative, but then anytime it was talked about, and I give an enormous amount of evidence and examples of this where children's safety was drummed up often, even well beyond when there was sort of an official narrative otherwise. And we can, I don't know if this is the moment, or we can get into it, and I suspect perhaps Machek and I may disagree on how much or whether at all school closures actually did benefit teachers or the community at large, which is a separate issue from children themselves gaining any benefit from the closures.
Yeah, and we can actually get into that a little bit now. So Maciej, how do you respond to that, considering all that was made of, safety for the children and safety and the risks for teachers and families and that and was there uncertainty at that point? He mentioned Andrew Cuomo, talking about different things, but how do you best navigate those risks? Were they fully understood at the time, and was there as much risk to, say, the kids and the teachers and the families? And
So I'll say first that we knew from the data in China through late February 2020, we knew from those data that there were very few pediatric hospitalizations, very few pediatric cases of COVID. The Italy data and the South Korea data, the next two places where the epidemic was severe, didn't have as rich of a data set, but it was clear once you got through March that kids were not getting hospitalized. So we understood as a community, who's we in this sentence? So we as epidemiologists, academic epidemiologists, public health professionals, we understood as a community that kids were largely not at risk of severe outcomes from COVID. And even the under 30s, and in your 30s, it's a little bit less, but even the under 30s were mostly safe. We saw the messages passing through the media and social media that we're doing this for the kids, that schools need to be closed to protect kids from the severe consequences of COVID. We heard Andrew Cuomo say this, and I read David's book, and there's examples in David's book of people saying this on social media. I mean, I think just want to tell everybody in this room and David that, we had microphones to say this stuff. Andrew Cuomo had a megaphone. So when our messages did get lost sometimes, and we didn't always control them when they kind of left our lips and went out into the social media and the media sphere. I was on the State College Area School District Board for the year of the pandemic, and this even came up in September in our school board meetings, and there was a high school student who, as a member of the school board, the high school had one 16-year-old who was a school board representative, who said the same thing, that he was afraid of what would happen to him and to his classmates if they got COVID. And we had to walk through this at school board meetings, that actually for, your probabilities of hospitalization or severe outcomes are very low. I don't know what caused the messaging to go this way. And actually, David, I'd like to know from you, Wilk, if we can do an extra minute.
Yeah.
Why some of these messages were lost and some of the wrong messages got heard by everybody.
Yeah, take a minute. Yeah, very good.
Unfortunately, many of, or at least some of Machek's peers did not share your reasonable and accurate understanding of the epidemiology. And I spent a lot of time thinking about this and researching and writing about it in my book, where I cover it extensively. And what I would argue is I put together a series of case studies of the media. And that is a large, in my view, a large reason why reasonable voices didn't gain the notoriety that they should have. Why is it that a reporter at the New York Times didn't contact you? And one of the things that's really important is thinking about the political tribalism in our country, and also thinking about the elite institutions within our country. And when you think about, by and large, who is in the sort of prestige media, these are people who, by and large, are on the left. And because the pandemic was so politicized, I would argue, in America, there was that a sort of open it up position was branded as right wing and as Republican. This is what Trump and other Republicans were in favor of initially and throughout the pandemic. And it became basically radioactive for anyone, even remotely on the left or within sort of elite society, to even be seen as aligning themselves with that. So you had places like the New York Times where the journalists who are really in some ways have their hands on the rudder of where the ship is going, the narrative, they had a very short Rolodex of who they called upon. There were the same people over and over and over again, including, an emergency medicine physician who now got rewarded for her punditry. She's now the head of some public health school at Yale. She knows far, far less about epidemiology than Machek, yet she had no problem pontificating about all sorts of interventions and what should and shouldn't be done in the New York Times and CBS, the Washington Post, and on down. There was a very short list of people who were given a voice, and this is deeply problematic.
Yeah, I think it was too. Did you have that same experience? Did you feel that there was a very small list of people within your circle of colleagues or whatever that were actually being consulted on this?
Yeah.
And that the true and accurate story, maybe that's bad wording, but it wasn't actually getting out there the way that it should have been?
Yeah. I'll address that point, but I also want to defend a couple of my colleagues who are going to be watching this, so they'll be expecting a defense.
Okay.
Before this debate, I just got in touch with a half a dozen colleagues who, kind of had to remember what they were doing 4 or 5 years ago. And I asked them, did you say this? Did you go to the Texas Department of Health and tell them all this stuff? And they said, no, of course not. It's not true. So why would I say it? I was an advisor at the Massachusetts and Rhode Island state departments of health and at the State College Area School District. And of course, I never told anybody that kids were going to die in large numbers if they got COVID. I think David's right about the short Rolodexes. I did a lot of media stuff and science communication during the pandemic for about 2 years. I had colleagues, some who became social media stars, who probably did 10 or 20 times as much as I did. And I don't know who it was by name and maybe you can tell me later privately or to everyone. I don't know who it was by name that was getting these messages out, but yeah, they were the wrong messages to get out.
Yeah. Yeah, thank you for that. I don't think we need to call anybody out by name today, but I think it's an important recognition that this was something that many people in my camp, so to speak, many people that were looking at the pandemic response and seeing some serious problems, from a layman's perspective, obviously, but looking at these different things that were happening and I always say they didn't pass the smell test, right? The things that we were seeing in real time were not the same things that were happening or being told to us in the media. And I think to David's point, it's kind of why he, as an investigative journalist, and I know you talk about that in your book, why you took it upon yourself as an investigative journalist to dive so deeply into that. So while we're talking about experts, this is a big thing that I talked about in the early days with Francis Collins It's or Dr. Francis Collins. It's why I became known for a while there as the collateral damage guy. But Maciej, talk to me real quick about other experts, right? And did they fail to look at the secondary harms of the actions that were being taken in terms of a public health response? Because I think and I don't ascribe motives to people for what they do or why they, but I think personally, and I know a lot of people that I've had conversations with have had the same argument that the secondary harms of the actions, especially the MPIs, were not adequately accounted for in the pandemic response. Can you talk to me about that for a couple minutes?
Sure.
And then we'll get David to weigh in as well.
Yeah. Yeah, I think it's true. I mean, the secondary effects of the pandemic is, probably the most important topic for us to talk about today. And were they adequately addressed? I mean, in some cases, yes. In some cases, no. We all understood that there would be a massive economic crisis as a result of the pandemic. And Congress twice passed bills injecting $4.5 trillion into the economy. And they, use this to solve the crisis, to put money into people's pockets and to help people meet payroll all across the country. 5% of that money ended up going to schools. And it, sounds like a lot of money, hundreds of billions of dollars. But what it means for Philadelphia, for example, is that Philadelphia, the last week of March 2020, got $112 million for their pandemic response. And that $112 million for an underfunded school district is like a 2.5% boost to their annual schools budget. And you can't say that, these school districts felt like they were being supported. So in some sense, I feel like we viewed the economy as the place where we had to correct some of the negative effects of NPIs. And then all the other aspects, things that are listed in David's book, whether it's schools or loneliness or how people felt for those couple of years, I felt like we as a society, our government, whoever it was, whoever this we was in the sentence, I don't think we did enough.
Yeah. And David, if you would have been advising people back during the response and especially in the early months, but as the things, the response protocols were carrying on, if you had an opportunity to advise some of the people that were making some of these decisions, whether it be financially or otherwise, what would your advice have been, knowing what you know now, but also taking into account what maybe you didn't know then?
Well, I think to some extent, even the framing of your question is wrong, which is, what would I have advised those people? Because the real question is, why was it just those people? And when your infamous, I think, interview with Francis Collins with his comment, which was very admirable that he had the candor to say this, where he said to you, I'm going to paraphrase, but we focused almost entirely on trying to mitigate this virus, and we attached zero value to everything else, and that was a mistake. Mm-hmm. And I think that comes from a good place. Why do people go into public health? I assume Machek, why? Because you care about people. You're interested in science. You want to help. That's a very noble way to spend your professional life. So I don't ascribe ill will or bad motive, but one of the things that I think is really important is to think about incentives. And there's some interesting studies that look at public health officials and where they've surveyed them in the past and saying that even when officials or just people within the field knew that a particular intervention wasn't working, I'm not talking about the pandemic, I'm just saying other public health interventions, that they still wanted to continue the intervention because it, quote, felt good to feel like you're doing something. This comes from a good place. If you go to your knee is hurting you, you go to the orthopedist, they're likely to try to prescribe something. Here, maybe it's surgery, maybe it's acupuncture, maybe it's some steroid, maybe you'll get a steroid shot, maybe you're just going to take some NSAIDs. They want to do something. They don't want to just say, this might just be a bad knee and I don't think I can help you with this. And unfortunately, there was a degree of, this is a little bit too harsh of a word, but a degree of hubris among the people who sort of architected the response, and that they felt like we had far more agency and far more control on the big dials of society than we actually have. Most interventions within medicine and within public health don't work. It's really, really hard to get a new drug that passes phase 3 of a randomized trial and is actually going to be shown to be safe and effective. It's really hard to get these things, whether it's medicine or non-pharmaceutical interventions, to find things that really work, because the world is complicated, our bodies are complicated. And there is a degree of certainty within which these people in charge, I think, presented themselves and the effect of these various interventions that was wildly unwarranted.
Yeah.
And that led to the harm that Collins ultimately admitted, which was this belief that we could turn the dials on society, and this lack of concern and lack of consideration for what an economist might call second order effects, which is the cascade of consequences that you may or may not foresee from once you put your hand on the dial.
Yeah, and I think it's an incredible point that you make there, and the one thing that I would say that I've heard a lot of people talk about is, these immediate risks, and we've got to do something, because if we don't do something now, it can get away from us and whatever. So I've got a question that I'd like you both to kind of take a minute or two to weigh in on, and I'll start with you, Maciej. But how should governments weigh immediate risks then of a viral spread against long-term harms like learning loss and whether it be economic struggles, mental health struggles, those kind of things? I mean, if this is something that they're truly worried about getting away from them, how do they deal with those immediate risks of a viral spread?
Yeah. Okay, so we've got the primary risk and the secondary risk, and there's even third degree risks, because to counter the second degree risk, we injected money into the economy, and then the third degree risk is inflation. Primary risk is the virus circulating. And while we're kind of talking about certainty and urgency, I just kind of want to remind everybody that this was a once in 100 years emergency. And when people spoke up with certainty, I did at moments. People asked me, will NPIs work? And I said, yes, they'll work. And somebody will be alive because, you chose to wear a mask for 30 days in a row. So we spoke with certainty because the nature of the emergency was, in fact, that high. You wake up one morning in March and 500,000 people are about to die, and you try to take the straightest line you can to the solution. And the solution is the rollout of the vaccine, and getting there is the difficult part. So now what do you do about all the secondary effects? Because you turn society upside down. You tell people that we're going to do NPIs for 8 or 10 months and then roll the vaccine out. And we didn't have the team assembled for this. And I think this comes back to leadership. So not only were we not organized as a national epidemiology core that housed expertise and was able to share data, but there were no sociology PhDs and education PhDs that were put on panels and asked, well, look, how do we get kids back into school to reverse their learning loss? And how do we combat, the isolation of the society that's already rural and people are contacting each other less than, they were before? I mean, if I had to fix one thing for the next pandemic, it's to bring all these other people in to try to fix and reverse these secondary effects. I mean, I think I'll leave it there. I'm curious to know what you guys think.
Yeah, David, I would like to, kind of get your input on that as somebody, because I've been asked that same question, and I don't pretend to kind of debate that with people who've had to actually make those decisions. But how do, from your perspective and from your experience, researching the things that you've researched, how should governments then weigh the immediate risks of viral spread against long-term harms, like we've seen the mental health things and the economic fallout, learning loss, things like that?
Yeah. No, I agree wholeheartedly with Maciej on the idea that, which I touched on previously, that it matters a lot who is directing, quote, the response. And I think it makes sense in the beginning if you're presented with a somewhat unknown threat, whatever it may be, that you want the people who ostensibly at least have the most knowledge about this threat. If we think a meteor is coming, well, then we're going to talk to all the astronomers or whomever else, or the people at NASA who might have the most knowledge. Let them guide us initially, right? So whatever the threat may be, let's go to the experts in that particular field initially. But what we didn't do was, after that initial phase happens, then we need to start asking, well, what's next? That makes sense for the first week or maybe the first month. But as Maciej said, where were the sociologists? Where were the people in education? Where were the economists? There was a moment where Anthony Fauci, I think, was being questioned in the Senate, and he said, well, I don't know about those economic things. I don't get involved in that. I just deal with health. Well, those economic things matter a lot for health. And the problem was that there's a person named Emily Oster, who's kind of like one of the heroes in my book. She's an economist at Brown. And she was vilified by a lot of people for saying she needs to stay in her lane. I was at a party with some New York Times people toward the end of the pandemic, and one of them, we got into a little bit of a thing about Emily Oster, and she said, why would I listen to her? She's just an economist. I'm going to listen to epidemiologists. I'm like, that's part of the problem, is that you were only talking to one group of people, and Maciej could speak to this better than I could. Not all epidemiologists even have an expertise in infectious diseases. There's all sorts of narrow, subspecialties within that. So there's not necessarily this idea that one group gets to decide how all of society is going to operate and what makes sense.
Yeah.
So I don't know if this just as far as the specific specificity of your question about what to do in the beginning. I think you do go to that one particular people with that narrow range of knowledge and expertise, but there needs to be a sunset on okay, we're going to let them kind of grab the wheel initially, but we need to start looking at these broader effects and understanding. And to my mind, that was really, with some small exceptions, not done, and that's why so much damage was done during the pandemic, including damage to people's trust and belief in the public health officials.
And I do think that played a large part in the degradation of trust between the public and public health, is because when they looked at things and the data that they were seeing and the real life experiences that they were living were not, comporting with what was being said, they started to lose trust. They began to say, hey, why, the things I'm being told, the things that I'm seeing on television, and the things that I'm having, constantly the fear and the it's just not my lived experience. It's not the same things that I'm living. And they did not see any course correction. So course correction, something that I've talked with Dr. Jay Bhattacharya about at length, is okay, we had certain things that were happening, and the narrative was staying the same when the data was changing, and the course corrections were not happening, and that played a huge part in that degradation of trust, which then brings me, kind of to the international part of this conversation. David, you highlight Europe, and a lot of people have highlighted Europe, and Sweden in particular, but other places in Europe, as reopening schools early on in the pandemic without major problems. We saw it. What lessons do you think that the U.S. should have drawn from some of the examples that they were seeing in Europe, but then they didn't course correct?
Yeah, and I want to also address the idea of course correction tied. I'll try to weave them together with the Europe question, which is indeed Europe began reopening a lot of their schools at the end of April and the beginning of May. Toward the end of May, the education ministers at the EU met, or at least virtually met, and they said, we have observed no negative consequences from opening these schools. And I want to be clear, this was not one school in the countryside of Denmark. This was 22 countries. 22 countries began reopening their schools. Millions of children, millions, were flowing back into schools in Europe, and they observed no negative consequence. Does that mean that there weren't cases, that are transmission in schools? Of course not. But it means that it was clear that opening schools, that schools themselves were not drivers of the pandemic, that whether they were open or not was not having a material, meaningful impact, an observable impact on what was happening in transmission. They met a second time at the end of June, and they had the same determination, again, about the lack of observable impact. And in the United States, I'm sure you all remember these meetings at the EU, because this was such an important thing. This is what we were told. We can't open schools. It's not safe yet. We need to do 6 feet of distancing, and the schools need HEPA filters, and we need to do all these lists of things. You guys remember that, right? How we were told it wasn't safe. And remember, the evidence from Europe, we had the guinea pigs, all those millions of kids, they were in school. Remember how this was on the front page of the New York Times and every cable news channel? They said, hey, everybody, we've got the news we've all been waiting for. They're in school and it turns out it's okay. Remember that? Oh yeah, that didn't happen. That's right. So they didn't cover this information, that much of the public was kept in the dark about what was actually going on. We were in this incredible American bubble of what was going on. And just to try to weave this in with your question about sort of being able to pivot, or whatever terminology you use, is that implementation science is a field where they look at implementing different interventions, often medical or otherwise. They'll see when we have hand washing stations in a hospital, how likely is it that the physicians or others are going to continue with this practice over time? And one of the things they know in implementation science is that, and this is a fairly obvious point, it's really hard to unwind something once you're doing it, even after there's evidence that it's either not effective or worse, evidence that it can be harmful. Mm-hmm. And this ties into my comment before about it feels good to just feel like you're doing something. It's really hard to stop. We all have a little bit of that kind of, knock on wood type of thing. People will continue taking medicines far after it's been shown that the medicine may not actually be beneficial for them, indeed may be causing harm. So once the gears started turning in America, in particular with school closures, for a whole variety of reasons, it became very, very hard to unwind, to stop, to put something in those gears to prevent them from turning in that direction. And this should have been known before this was happening, because people who know this stuff, who study implementation science, had they been consulted, they could have said, everybody, we got to tap the brakes on this. This is going to be really hard to go back. But sure enough, they weren't listened to, or they weren't consulted. And there was a thing, the line I use in my book, it's akin to Newtonian physics. We all know the, truism of an object in motion stays in motion, an object at rest stays at rest. Once that thing was in motion, it was very hard to stop that car from just kind of careening off the cliff.
Right. Yeah. So Maciej, then, what would you say, I guess, to somebody in the same vein of that argument about Europe and things were in motion, and the data that we were getting out of Europe, or maybe, what were the key differences between Europe and the US that made that, that comparison very difficult, that maybe contributed to them not pumping the brakes on that ball that was already in motion?
Yeah. So this is where David and I are going to diverge a little bit in our opinions. It's true that Europe reopened their schools in early May. I mean, in early May, you did not have evidence that opening schools was safe. They just reasonably tried to do the right thing by trying to open schools as safely as possible. There was only one place in Europe in March and April where schools were open, and that was in Sweden. Those data weren't favorable, but still it was the right thing to try to open schools in May. We didn't have that conversation in the US. I think I know why, but we can get to that later. We did not spend the summer preparing for opening schools in September. We did not spend time funding schools adequately to get them to open properly. And so now the we is epidemiologists, public health professionals, we understood that opening schools in September was going to pose some risk and was going to increase transmission. We understood that. Did we have the hard data for it yet? No, we didn't. We had past data from other pandemics and epidemics, influenza epidemics or other respiratory virus epidemics, that showed that when you close schools for a certain period, respiratory virus transmission goes down. So we cautioned schools in August, September. In my school district, I recommended that the school district open all 11 schools because I saw they had the right mitigation measures in place, and I thought it was a good idea for them to open. I don't know what I would have said in Philadelphia, where from everything I can see, I've talked to some people in the Philly school district since being here. From everything I can see, I don't think they were prepared. And we didn't have the data, but we have the data now. So all these years later, I mean, these data were available in 2022. We got the data to compare closed schools to partially open schools to fully open schools. And did disease transmission increase in partially open schools? It did by some amount. And what about fully open schools? It did by a slightly larger amount. How large were these amounts? About 10% to 15% for partially open schools, about 30% more virus transmission in fully open schools. So was it worth it to keep those schools open? I mean, this is the hardest question that we have to answer because there was a little bit more disease transmission. Was it a lot or a little, and did anybody die as a result? I don't think anybody knows, but this is the conversation I think we need to have now.
Yeah, and I think the conversation again just wasn't had, and kind of to David's point at the beginning in his opening statement, there's going to be a certain amount of risk, right, that comes along with everything. So as kind of a follow-up to that, and then I'll move over to David to ask him, but or kind of get his response to what you're saying there. What you said, you suspect why the conversation didn't happen, but I think there was a certain amount of evidence that conflicted. The evidence from abroad was conflicting with what was actually happening in the U.S. Why do you think that conversation didn't happen? And then just touch briefly, on the I guess I don't know. Let's just go there for the time being with why do you think that conversation didn't happen, and if that conversation had happened, could there have been a meaningful result there?
I mean, it's the first week of May 2020. It's the right time to discuss whether schools should open. And even though we understood in March that we needed to lock down, by May this consensus had broken down and we were just too divided. So I asked myself this question because I read David's book, and I'd forgotten that we never even considered this in early May. And I went back to my social media feed in May 2020 to see what was there. And the divisions were just plain in front of everybody. I couldn't visit my father in the hospital. COVID's deadly. I couldn't get the doctor to prescribe him hydroxychloroquine. Public health has failed us. On the other side, COVID's not deadly at all. It's a 0.01% death rate. We don't need to lock down at all. Public health has failed us. This was everywhere. So at this point, the public appetite for something like a mature conversation on whether schools should be open, I felt that first week of May, we were already in kind of the place we are now where that conversation couldn't be had.
How would you? Yeah, I mean, that conversation unfortunately wasn't had, and there was a certain amount of division that, well, not a certain amount. I imagine, like Machek, that division, that ugliness had already contributed to it. But I don't know. Talk about that in terms of, whether it be the course correction or why the conversation didn't happen. What's your take on that?
Well, there's a lot there. So I was like wishing that
Yeah.
I had brought like a pen and paper just to make notes to myself so I could remember all the different points to address, and it'd be impossible to do so in a succinct manner. But I think that Maciej described it well. There's, it's a very, very divided, acrimonious atmosphere in America, and it made having any sort of reasonable conversations basically impossible. But I want to, now things are getting spicy. I want to address some of Maciek's comments, which is whether or not, we were, quote, ready to open the school safely or do various things. I would argue that anyone was ready, that nothing in particular really needed to be done. The schools in Sweden did not do anything special in particular. Now, of course, Sweden is not America. It's a different society. But make no mistake, Stockholm is a densely populated major city, far more densely populated than much of America. And the rest of Europe, when they began reopening schools, they did not follow the protocols across the board that we were told we needed to do. Perhaps Maciej may even have advocated for some of these or believe that they were or would be necessary. But in the beginning, Denmark, I believe it was Denmark, had 3 feet of distance, or what would be 2 meters. They very quickly thereafter reduced it to 1 meter, or the equivalent of 3 feet. There are plenty of other places in Europe where they had no specific distance requirement at all in the schools. They did not have HEPA filters across the board. That was very unusual. Anyone here who's been to Europe knows they, by and large, don't use forced air systems. They did not have that. And in the colder places, the windows were closed too. They were not, so they weren't doing this distancing that we were told we needed. They didn't have the filtered air we were told we needed across the board. They weren't, they did not have mask mandates across the board. Indeed, unlike America, in much of Europe, the ECDC, that's the European version of the CDC, they did not recommend masks at all for kids in primary school. Now, some pockets in Europe, they were requiring them, but in many areas, they were not requiring them. They didn't have, my kids had to sit with their heads inside of this opaque barrier all day. They weren't using those across the board either. So all of these different interventions that we were told were necessary in order for schools to open, to be safe, these things were not used across the board in Europe, and yet still there was no observable negative impact. I would take issue, and again, I assume the audience doesn't want us to get in the weeds on arguing about different studies, but all the literature I'm familiar with does not show that there were particular benefits of school closures on mitigation, and particularly not benefits of a hybrid model where kids were in some days of the week and home other days of the week. There was evidence by the fall of 2020. This is not a proper study, but Emily Oster had acquired a pretty large data set from around the country. And I did my own sort of study, if you will, in Westchester County, New York, where I live. There's some 40 plus different school districts. It's all roughly a similar demographic. And I compared, and New York, to its credit, had a really good dashboard with all the data on the different school populations and the rates of cases and such. There was no difference between the schools that were open full time, that were, 3 miles away from where I was, a school open full time. Then you have another school that's closed. And then you have a third district where it's hybrid. There were no observable statistical differences between any of these districts, despite completely different models about how the schools were open. So one of the problems with looking at this stuff, which I mentioned at the beginning, is a lot of it depends on the parameters that the scientists or researchers choose. And I would argue that school closures probably do have a benefit, for sure, in a very limited window of time when they're done in conjunction if everything else is closed. But what we see, and you can see it from the mobile phone data, that over time, people began moving about pretty quickly. And it didn't matter what the rules were in their particular area. Why? Not because people are assholes, but because we're human. And even the introverts among us still need to see other people, particularly children. And keeping school, and there's a wonderful study by Robert Barrow that I cite in my book, where he looked at the 1918 pandemic. And you may recall, one of the lessons we were told to learn was, and I think Philly was infamous in this lesson. It was Philadelphia versus St. Louis. Philadelphia was
a couple seconds to go ahead and wrap that up.
Sure, sorry. Okay, so I'm a little long-winded.
Yeah.
There was so much.
Yeah.
Philly was the villain. There was a big spike in cases in Philly in 1918 because they didn't have enough things closed. St. Louis did the right thing, and they had the nice gentle slope of cases. But what Robert Barrow looked at over time was that, yes, that looked a certain way in this specific window of time, in the same way when you take a photograph and you have it cropped and you don't see the guy holding a gun just outside of the frame and you don't know what's going on. When you extend it out over a long period of time, and this was going to be a marathon, these things were not effective. You cannot expect human beings to be sequestered for that time, and especially because something like a third of the population were out working. And these people were never sequestered at home. So these interventions can be effective, but a lot of it has to do with how long you expect them to be implemented. People just simply can't comply with these types of interventions over a long
For
period
long
of time.
periods of time. Yeah, that did get a little spicy and a little long. And
Sorry.
no, that's fine. I got one more question that I want us to get to, but I want to give Machek a couple
I didn't
minutes
mean to
to.
filibuster this.
No, but I mean, I think you make an important point, and I want Machek to respond to it. So Machek, take about 3 minutes to respond to that. I mean, there was a lot there to unpack, and I'm sure you're catching on to a lot of it. But take about 3 minutes to respond to that, and then we'll get to our final question for tonight.
Okay, I'm going to request an extra minute because we're at my favorite part of this, which is the data.
There you go.
Yeah, let's
We'll go 4 minutes.
Let's do Europe first. It's true that European countries reopened their schools more than us in the fall of 2020. They were closed a bit more in spring 2021 than fall 2020. European schools did have various measures of masking and distancing. It was 3 feet, like David said, in many schools. And the combination of these measures had its own set of outcomes. And I actually don't know if in Europe, daily testing had an impact on reducing COVID transmission. In American schools, it did seem to have an impact on reducing COVID transmission. So it's not accurate to say that they just opened up and everything was fine. And I think Sweden's probably the best example here. Sweden was a poster child of people's pandemic images, maybe a Rorschach test of what they thought the pandemic was all about. In Sweden, in the end, for that first year of the pandemic, pre-vaccine, they had 12 or 13,000 deaths. It was 6 or 8 times higher than Norway or Finland and much higher than their other neighbors. And they admit now that they did not pursue a terrific pandemic policy. Now, I want to talk about, I realize I only have a minute and a half left, about what the New York Times and the Atlantic published in September, October 2020 to kind of tell us that schools were safe. And I just want to say for the New York Times, they published both sides. They would publish on Monday that schools should be closed and on Tuesday that schools should be open. There were a lot of people writing in with their opinions. The opinion pages showed a lot of things. But I'll just take this one early October Atlantic piece. David, I'm sorry for throwing your publication under the bus here. But the message in this piece was that they'd collected all this data from schools and that only 0.24% of teachers had gotten infected. And you see this number in black and white, and it feels small. Just 0.24% of teachers infected. If someone offered you 0.24% on a checking account, you would say, no, thank you. And if someone offered you a 0.24% mortgage, you would say, terrific. I'm not going to have to pay any interest for 30 years. And what they didn't tell you is that in the 2 weeks they made that measurement, 600,000 Americans tested positive for COVID. That's 0.18% of the US population. So teachers were about at the same level of risk as everybody else in the population, maybe at a slightly higher level of risk because the sample of schools may have been biased in one direction or the other. But the Atlantic and the New York Times didn't give you that piece of information, and they took the best period of the pandemic, September, the lowest transmission period of the pandemic, and they said, see, it's low transmission. And a lot of us said at that moment, guys, it's low transmission for now. There's a forest fire 20 miles away. It doesn't mean that it's going to be low transmission forever, and we still have to prepare for the wave of infections that's coming.
Yeah. Well, yeah, I mean, there's definitely going to be some points of agreement there, and far too much to get into tonight. I mean, it definitely, where we look at the data and how we evaluate that data and what point in time that data came from, and that's why it's so important to continue having these conversations, because again, there's so many different things that could be looked at when it comes to the pandemic or the pandemic response and how best to evaluate the data. One of the big things that I've often said in the conversations that I've had with some of the world's most esteemed medical professionals and scientists is, how do two people look at the same data and come to a different conclusion? And that's that is part of science, and that's part of why these conversations need to continue happening, because when we stifle those conversations and don't have those conversations, we're not able to course correct when we need to course correct. So I've got a couple real quick things that I'd like to finish up with real quick. A couple questions for each of you to answer in terms of this whole thing overall, but also our conversation today is, and then I'll give you each a couple minutes to answer. Is as we consider the possibility of future pandemics, and what principles should guide how we allocate our resources to schools, what principles should guide how the conversation is happening, and overall, what principles should guide us as a population, as a society, and where do you think? I'm just going to kind of roll this into one question for each of you to take 2 minutes. Where do you think we actually may have agreed more tonight than you maybe previously thought you would have before this conversation? So, David, I'll start with you. Future of pandemics, and then kind of wrap up your comments with where do you think you may have agreed more with Machek than you maybe previously thought you would have?
Well, I think the theme tonight, we definitely agree upon is that you need more voices. And one of the things, that I talked about earlier tonight was the idea that you have the quote experts on a particular area, but then those people shouldn't necessarily be the directors of society for some unknown, indeterminate period of time. But that's exactly what happened, I would argue, at least during the pandemic, that you had Anthony Fauci, Deborah Birx, and these other people, that there became this very kind of incredibly, the aperture just shrunk down to this one thing of importance, worrying about COVID deaths. And I like in my book, I talk about, you can imagine like a scoreboard, where it became almost gamified, where you saw this thing on the front page on the homepage of the New York Times, on cable news, et cetera. You saw a number. It was as if you were in a Vegas casino, and it was a morbid curiosity, but there's a reason why I was stuck in traffic for the accident, because people rubberneck. And although people were horrified, they wanted to look at that number every day. And people talked about that number. What were the cases? Were they going up? Were they going down? What was happening with the hospitalizations in your area and someone else's area? That type of sort of gamification, I would argue, distorted our perspective on a holistic view about how to approach a pandemic, or any crisis for that matter, and how we live in society.
Mm-hmm.
I'll leave it there.
Yeah, no, that incredible. Yeah, no, good point. And yeah, as far as, so then in terms of the same question, the guiding principles and how we look at future pandemics, and what principles should guide us as a society, should guide the professionals, and then also to the same question is what is there that you may have agreed with David on, that you may not have believed in coming into this conversation?
I mean, I'll say first quickly that I saw the gamification of dashboards popping up everywhere with reds and blues and greens and death counts and hospitalization counts. I just want to reassure everybody that we did not view this as a gamification. We understood that there was a real thing that we were managing, and if you could, save 50,000 additional lives, that was, the direction we were going to go. I think for the next thing that we're going to do to improve our response to another pandemic, I mean, I'll just go with David's phrasing that we need more voices. So, we've already talked about, what would it have been like if we had 1,000 sociology PhDs and 1,000 education PhDs telling us this is how you get kids back into school. And, why don't we just bring economists into this, because they came up as well. I mean, we had other economic challenges besides people's paychecks. So, there's things that we don't know how to do. You need 25,000 contact tracers. It's an emergency. How do you create a labor market for this? I need to talk to an economist, but they're not around. You need to manufacture 100 million doses of vaccine, but you don't know what the efficacy is, and the demand isn't The demand isn't able to be estimated right now. You need an economist to walk you through those variables and all that uncertainty so that the vaccine can be manufactured early and distributed. And I didn't feel that we, as a society, this is not we epidemiologists, I didn't feel that we had all this support and that it was organized very well. So I'll say that, yeah, more voices next time, better organization, and I'm just gonna come back to it, Wilk. I mean, without leadership, none of this happens.
That's absolutely right. That's absolutely right. I mean, we need to be personal leaders in our own environment, in our own bubbles, in our own circles of influence. We need to make sure that all voices are heard. That's why Braver Angels is such an important organization, right? We encourage all people to stand up, have conversations with people they disagree with, and keep coming together, speaking freely, fully, without fear. And I just can't encourage people enough to demand better of leaders and demand more of those people who represent us, and keep talking with people that you disagree with, and do it in the most meaningful and reasonable way possible. Because if we shut down the conversation, we get what we just had in terms of a pandemic response. We don't get people represented the way that they need to be represented, and there is distrust. The only way we regain it is to keep having conversations. Braver Angels is a fantastic place to do it. If you guys didn't get one of my cards, please do go to braverangels.org to learn more about this organization. And if you, if you want, reach out to me. Please stick around. There's food across the hall for everybody, and then we've got a great debate, community debate that our director of debates, Jesse Manisto, is going to do. So I'm sorry there wasn't a lot of time for question and answer, but maybe we can kind of get that question and answer thing done in the community debate or in our little social hour. Jesse.
What can the online viewers do if they want to participate in the debate?
Here.
Oh, I guess I'm up.
Yeah.
Hi, everyone.
Is that working?
There we go. Hi. I don't know where the screen is or the
It's right there.
camera's-
Camera's right there.
Hi. If you're watching at home and you are hearing about this community debate that we're about to have, which is going to be great, I'm sorry you're missing it. We're doing it on September 11th as a national debate. Resolve, trust the science. So if you've been inspired by this, whatever you think, whether it's public health or something else, we'd love to see you on the 11th. And the rest of you, I look forward to seeing you after the break.
Very good. Thank you, Jesse. And thank you all for showing up here tonight. Thank you those of you online, again, showing up not just for this, but truly showing up emotionally, intellectually to think about these things. They're important, and thank you so much. Appreciate it.
There's no Q&A.
We can do Q&A. Do you want to do a little Q&A real quick? Anybody who wants to stick around and do a quick Q&A in here, that's fine. If you would like to go grab some food across the hall prior to the other debate. Machek, do you want to do a couple Q&A questions?
Sure.
We'll keep the live feed going. We'll do a couple Q&As. So, Jesse, can you do me a favor and run the mic? Yeah, we'll do a quick Q&A. Who do we got? Who? What?
Point, there's a few hands.
Yeah. Okay. This gal right over here has a question.
Yeah, I have a question for Maciej, and also if you have any insight, David. But my question is, when we look at some of the other third world countries that are densely populated and don't have, as much advancement in technology and medicine and all of these things that fared better than we did, what has your community believed to be the reason why we did so much worse than them? I have my own reasons, but I don't know what you think.
Yeah, there's a lot of different answers here. It was a little bit of a mystery for about a year as to why the COVID death rate was so low in Africa. And basically, it looks like it could all be attributed to age structure. Because the African population is younger, you have fewer individuals over the age of 60, and the vast majority of COVID deaths happened in individuals over 60. So the thing that we say that first year pre-vaccine, 73% of people that died were over 73. That's kind of the thing to remember. So you had a low death rate in Africa for that reason. In East Asia, you just had the memory of the original SARS pandemic 20 some odd years ago. You had the memory of a pretty successful swine flu response, of avian influenza outbreaks. And when COVID came, they were ready. And so you had a half a dozen, maybe a dozen East, Southeast Asian countries that just prepared, closed their borders, had excellent contact tracing and quarantine. And some of these countries got away scot-free with low infection rates and low death counts until the vaccine arrived.
David, do you want to touch on that, or?
Go.
Okay. Right here. Yes. Yes.
Yeah, I appreciate the conversation. And I think what's being suggested is where were the values around trade-offs? Because if it was mostly older people dying and younger people experiencing isolation and learning delays, how would you have structured, or how might you structure in the future, very difficult trade-offs among who experiences what implications? And that's just the age one. But then you have the socioeconomic of frontline workers who are out and being exposed, and wealthier knowledge workers who could stay home without as much disruption. So how would you orchestrate a national conversation about values and the trade-offs?
David, you want to take a minute?
Sure,
Yeah, I mean, I
yeah.
think it's important.
I mean, the COVID pandemic was one of the most classist policy events in a generation, if not many generations, where you had the lower classes, by and large, working people were out working, while the virtuous, wealthy laptop people could stay home. The academics, the white shoe lawyers, the whomever else, they could do their Zoom meetings at work from the comfort of their home, while everyone, and they were virtuous for doing this, by the way. And then there was a lack of virtue for the people who needed to go out and actually get their hands dirty. I mean, it's hard to even craft a narrative if it were, a fictionalized story where you have the good, virtuous people being waited on by the poor people who are in the slaughterhouses, who are in the Amazon warehouses, who are driving the trucks, who are the cashiers. All of these people had the gears of society turning, so the good people, the wealthier people, could be home. And it is quite telling that the people who came up with the pandemic policy, who came up with the models about that sort of orchestrated what we would do, well, those people were in a particular class. I guarantee if the people who are orchestrating the response lived in a studio apartment in the Bronx with 6 other people without a functioning air conditioner, they would have a very different view on what made sense, on what we should do and who should be home and who should be allowed out.
Yeah. You want to talk a minute about trade-offs?
Sure. I mean, I just want to say I don't share David's view about how we made some of these decisions. We did not think that we would be safe with our laptops. We had other reasons for recommending things like masks and lockdowns. But I'll say about the trade-offs, I'm just going to say the very standard public health thing here, that, we view death as irreversible. We view economic damage and learning loss as reversible. So we viewed this as a single primary goal, which is something close to what Francis Collins said, where if kids lose a half a year of education, there has to be some way to get that back. But if you lose your parents, there's not going to be any way to get that back. And just think about what the goals were in 1941. This was, our country's biggest crisis since 1941, March 2020. You had this one thing that you needed to achieve, which was the defeat of fascism and imperialism. And we did that at great cost. And then everything else fell into place. But if we had lost that first battle, none of the other things would have fallen into place.
Thank you. Let's get one more question, or we'll do two more, and then we'll go over next. Yes.
Thank you so much for the conversation. It was fascinating. I don't know who to put this to, but it's things that you both touched on. But I'm just wondering, kind of in your opinion, how much and David, you had mentioned this, just the desire to do something and to act in some way when faced with the uncertainty, and how much do you think of the response of top public health officials was just a desire to embody an amount of certainty, even if it wasn't, even if there was no way that it could be 100%? How much was that desire to kind of protect, to embody a sense of certainty? How much was just that kind of human nature to be that person who says it's going to be okay, here's what we have to do, with that level of certainty? How much was that versus how much was we are actually very certain about this, and that's why we're espousing this level of certainty?
Yeah, I mean, I can't profess to get into the heads of the people who are making pronouncements publicly, but as you noted, people go into public health because they think they're going to make a difference. That's what and it's a noble goal. But what we also know is that, and I cite some studies that show this, some interesting examples, and there are many of them. People in public health tend to overestimate over and over again the impact of their interventions. And I think that was manifest during the pandemic. I suspect Machek disagrees with me, but I would argue that was manifestly true during the pandemic, that there was a vast overestimation about the likelihood of benefit of a lot of these interventions. So I think, I would like to believe this came from a good place from a lot of these people, that they felt like this was going to be far more effective than it was. And I also think, not in a nefarious way necessarily, but what we did observe was a degree of authoritarianism that many of us had not experienced before. I certainly hadn't. And it made me realize how much I do value personal liberties. And that's an incredibly important part of the American experiment. Is we're a highly individualistic country, and there are pluses and minuses to that. But when you are going to put your hand on the master switch of society, when you are a public health expert in Santa Clara County in California, and you're going to tell someone who's spent the last decade of their life going to church every week that you're not allowed to go anymore, and this is someone who suffers from addiction and relied on that community. You said, no, you're not allowed to go anymore. The malls can be open. Someone can go to a bar. You can't go to church.
Mm-hmm.
That's a problem. And I think personal liberties are not something to be taken lightly. It's not that there isn't room for our officials in charge to sometimes have to intervene and impose restrictions on us. But in my view, that authority ran amok during the pandemic, and it wove together with the deeply partisan nature that took over in the country. And it's a bit funny, but I couldn't figure out, was on the, I don't know if this is, they're trolling me or what, but there's a mask on the table. I know someone put this here as a joke. They're just messing with me.
Yeah.
But we had these symbols of what team you were on.
Yeah.
And that's ultimately what happened. And what we observed was there was a team who were very, very comfortable with the government telling everyone what they had to do.
Okay.
And there was another team who valued personal liberties in a different manner.
Let's give Machek a minute or two to respond to that, and then we'll.
Yeah, I'll be quick because I know we're winding down. I'll just address the certainty question. We didn't have certainty the first week of March 2020 as to how large the first wave would be and how large the entire epidemic would be, but we had enough certainty to make a decision. So we couldn't tell you that it was going to be 75,000 deaths in the first 2 months, which it was, but we had enough certainty to know that it was going to be a large number in some range and that it was now time to say something or do something. So, what happens in these situations? Do you have certainty that a hurricane is going to arrive tomorrow at 6 o'clock or 10 o'clock? You don't have that certainty. But you do have the certainty that you need to tell people to evacuate. Does that violate their personal liberties? I think a lot of people might say that it violates their personal liberties to be told to evacuate their homes. And we live in a democracy, so maybe it's now time for us to assess as a society what we should do if we're told to evacuate in a hurricane or lockdown during a pandemic or some other emergency. At the end of the day, this is up to us to decide what we want to do in these situations.
Yeah. All right. Very good. One last question right up here up front, and then we'll wrap up and move on to the next part of our evening.
Could the panelists speak to the role of moral panic and censorship and cancellation campaigns, especially on social media, that in terms of increasing the inertia and the difficulty of changing policy in response to new data, and also ultimately creating a public backlash of increased skepticism toward public health messaging and what was represented as expert consensus?
Awfully hard to do in a minute, but yeah, go ahead and take a shot at one.
I was about to say, we have an hour, right? That was like 15 questions in one. I don't even know which do you want to tease one piece of that out?
I don't know how the velocity of information coming from social media and moral panic and I don't know, and what? Yeah, cancellation, censorship, moral panic, social media.
As you know, you've become friendly with Jay Bhattacharya, and who's now the head of the NIH. He was censored by Twitter, which is now X. I was one of the journalists part of the operation called the Twitter Files, where we did uncover a lot of evidence that everyday Americans, and including physicians, were censored in one way or another. Their voices were limited. They weren't always removed from a platform, but they could be down boosted in certain ways, these algorithms. And there's also, I believe, very persuasive evidence that the United States government jawboned these platforms, which means they may not have said, you are not allowed to do this, but it's kind of like, nice social media platform you got there. It'd be a shame if something happened to it.
Right.
So I think it was a very dangerous place. And the remedy for bad information is not to try to censor people. It's good information. Freedom of speech is the freedom to be wrong in America. And we don't want, in my view, the government deciding who is and who isn't correct and what is not true.
Mm-hmm. I like it.
I'll just do a minute on this. I mean, let's say, let's take Moms for Liberty. Let's say Moms for Liberty comes out with a campaign saying car seats are really unsafe for kids and we shouldn't be putting our kids in car seats, and 1,000 people believe it. And then a year later, 1 million people believe it. And then 50 million people believe that car seats are bad and we shouldn't be putting our kids in car seats. Should the government step in? Should we step in? And should we try to get people back into putting kids in car seats? We live in a democracy, and that's up to us. I think it's reasonable for us to put out good information, to get allies, to step in and say, yes, please put your kids in car seats. It's the right thing to do.
Yeah. I was just going to say that. I agree 100% that the best way to combat good or bad information is with good information. And I also want to say Moms for Liberty hasn't taken no stance on the harms of car seats. They're very important. We want to keep everybody in car seats that should be in car seats. Again, thank you. Thank you all for joining us tonight. And thank you again to everybody online. And thank you to our panelists, David Zwig, Machek Bonnie, Dr. Machek Bonnie, and Braver Angels. Thank you so much. Y'all have a great night.